afternoon, everyone. Is my slideshow visible?
Yeah.
Thank you, Rajesh sir and Namrata ma'am and AIOS for this wonderful opportunity. I'll be talking about medical management of glaucoma and why we should start early and why lower, fewer is better in glaucoma management. As we know, glaucoma is the leading cause of irreversible blindness, not only in our country but the world across, and this has to be emphasized again and again to improve the awareness. And blindness in glaucoma is quite common. Not only blindness, but disability is also very, very common. Poor quality of life is very common, and that has to be emphasized. The risk factors for developing blindness in glaucoma are higher IOPs to begin with, worse visual field status at baseline, and older ages. So the management of glaucoma, the goal is to maintain the patient's visual function as well as related quality of life, all at a sustainable cost. So all these 3 points are very important: the patient's visual function maintenance, as well as quality of life. The aim is not only to prevent complete blindness, but to prevent a poor quality of life as well. All that at a sustainable cost. So how the quality of life starts deteriorating in glaucoma in the early stages, the driving starts becoming difficult with moderate glaucomas, mean deviations of -10. Patient starts to fall more often. -15, reading becomes difficult in advanced cases, and in severe and end-stage glaucomas, patients are not able to move around on their own, even from a room to the other. So the treatment should be focusing on prevention of these patients to go beyond -15 decibels of mean deviation, or in terms of visual field index, 40% or lower has to be considered as the line where we need to stop the progression before that. So which patients need to be treated? Ocular hypertension, Dr. Vijay Lakshmi elicited all the major points here. Not all patients of ocular hypertension requires treatment, but yeah, close follow-up of these patients are very, very important. And however, once glaucoma has developed, regardless of its type, treatment has to be started on the basis of the concept of rate of progression. So there is a normal visual decline also that happens with age, but it is very, very slow at around 0.06 decibels per year, and usually doesn't cause much of trouble to the patient. But untreated glaucomas progress very, very fast, more than 1 decibel per year, and even patients on treatment can progress at a rate of around 0.4 to 0.6 decibels per year. So these are the different rates of progression, different types of patients that you see in your OPD. The green dotted line is the normal visual decline with age. Again, you can see the rate is not very fast. B, the blue line that you see here, is a patient who has been diagnosed with glaucoma at the later part of their life, at an older age. The rate of progression is moderate, but not as much as to cause severe visual impairment during their lifetime. C, on the other hand, the yellow line, is basically a patient with a similar amount of visual field damage at diagnosis, and the rate of progression is also similar to the B line. But these patients have been diagnosed with glaucoma. The age of disease onset is quite early in their life, and hence they will cross into severe visual field impairment during their lifetime. So these patients require much more aggressive treatment as compared to B. D line that you see here, the purple line, is again a slowly progressing glaucoma. Again, will not require much of an aggressive treatment. E, on the other hand, would be a very fast progressing glaucoma and would lead to complete blindness during their lifetime. So they have to be treated aggressively. So this is how different trajectories of visual field loss happens in glaucoma, and this has to be evaluated for each and every patient. As we know, intraocular pressure lowering is the only modifiable risk factor that we have in treatment of glaucoma. So we need to set target IOP for each and every patient who comes to us, and the factors that we need to consider in evaluating the target IOP would be the glaucomatous damage at onset. What is the life expectancy of the patient? What is the untreated or the baseline IOP? Are there any additional risk factors? And what's the rate of progression? So if the patient is having advanced glaucoma, long life expectancy, lower baseline IOPs, having additional risk factors, and are fast progressors, we need to set a lower target IOP, probably in the range of low teens or even single digit in advanced cases. Whereas if the risk factors are favorable, we can think about setting a more lenient target IOP in the mid-teens or even the high teens. So as discussed, the risk factors are thinner corneal thickness, family history, gonioscopic findings, pigment dispersion, pseudoexfoliations, they tend to progress much faster. And other systemic diseases also needs to be considered. But and once the rate of point here is that target IOP has to be individualized for each and every patient. It cannot be a single value for everyone. And it has to be evaluated according to the risk profile at the time of diagnosis. The target IOP, there are how to set it. There are many ways of setting it. Some studies tell us to reduce the IOP by more than 25%. 15 to 18 mm Hg in certain studies have been considered a good starting point. But again, I would like to emphasize that the target IOP should be individualized at the diagnosis, and it may need adjustment during the course of the disease as well. It's not a single value that the patient will carry with them during their lifetime, but it has to be reevaluated again and again during the course of treatment and modified accordingly. The European guidelines tell us to set an IOP of less than 18 at early glaucoma, less than 15, less than 12 in advanced glaucoma, less than 10, that is single digit in terminal glaucomas. Again, this could be a good way to do it. So the initial treatment is usually medical therapy in most of the patients. And in medical therapy, prostaglandin analogs and beta blockers are usually the first choice. We need to evaluate the contraindications, and then usually PG analogs are the first line of treatment because they have a relatively higher safety, systemic safety. The efficacy is the highest. The 24-hour IOP reduction is better as compared to the other drugs, and the dosing is very easy. Just once a day drop should be enough. In medical management also, PG analogs, like I told, have the highest efficacy. In them, bimatoprost followed by latoroprost and travoprost have very good efficacies, followed by timolol. The difference between 0.01% bimatoprost, 0.03% bimatoprost is not very high, but 0.01% of bimatoprost gives lower chances of hyperemia in our patients. So the key point number 3 would be to detect early visual field progression in patients. Early visual field progression has been noted in almost 15% of patients who have been started on treatment with good IOP reductions. Even in them, 15% patients, they progress, and these patients need to be detected early. So once you get a patient, you evaluate the patient, you set a target IOP, you reevaluate the patient after 6 months, look for progression, and if progression is there, you consider a lower target IOP. If the condition is stable, you keep on following the patient 6 monthly or 1 year and look out for progression again. If the patient is stable and the target IOP is reached, that means the target IOP that you had set at the onset was correct, and we need to again keep on re-evaluating those patients, probably 6 monthly or 1 yearly. If the target IOP is not reached, but still the patient is stable, that means the initial target IOP that you had set was a little lower, and we can re-evaluate and set a slightly higher target pressure. So if the target IOP is not reached, on a single medication, then you can add a second drug. Even if after adding a second drug, the target IOP has not been reached, you substitute the second drug, or you give a combination of two drugs, you verify the efficacy and tolerability, and or consider other therapeutic options like surgery and laser. Bimetoprost timolol combination, fixed dose combination, PG analog with timolol have a complementary pathway of action, and hence is a logical combination to give to our patients because they are the two drugs which have the highest drug efficacy. Comparing with non-fixed combination, they tend to have non-inferior IOP reductions, having the advantage of a single drop for the patient to put as compared to 2 or even 3 drops in non-fixed combination group. And they are tolerated better because the amount of preservatives that go in the eye over a period of time is reduced to half or even less than that. Compared with bimetoprost and timolol separately, they have the combination has shown better efficacy in IOP lowering capabilities, as well as compared with other PG analogs. They tend to bimetoprost tends to be a little better. Compared with other combinations like dorzolamide timolol combination, again the IOP reduction was better with PG analog timolol combination. And cost effectiveness, yes, this is a very, very important factor that we need to consider. Cost, but if we analyze it further, we know that a single drop of a PG analog timolol combination would produce much lower IOP as compared to other combinations. And if we consider the cost effectiveness, cost per mmHg decrease in IOP, then bimetoprost timolol combination is not much different from the other combinations like dorzolamide and timolol. Tolerability also, there are side effects that we need to evaluate again and again over a period of time in our follow-ups, but these are usually very well tolerated. Conjunctival hyperemia being the most common, but we need to tell the patients that this would be a temporary phenomenon, and this is not going to affect your eyes in a very bad way in the future also. And to conclude, once the patient is diagnosed with glaucoma, we need to characterize a risk profile and plan an individualized management strategy. The main factors to consider are the visual field damage and the intraocular pressure. Other factors like that have been discussed by the previous speakers also needs to be considered here. Target IOP can be estimated accordingly, like I discussed. Patients showing a meaningful risk profile may benefit from an earlier and lower IOP reduction with medical management to begin with. And highest efficacy has been achieved by PG analogs, and amongst them also bimetoprost is the most efficacious one. At follow-up, early and fast progressors deserve an additional earlier and stronger intervention. And these patients may benefit from a PG analog timolol combination. That's all from my side. Thank you.
Thank you.